Hello, everyone. My name is Matthew Webb, and I'm a student physical therapist with a CSCS and a BS in nutrition science. Today, I'm going to be talking about riboflavin or vitamin B2. This is going to be the second in a series of educational videos intended for healthcare professionals to help us in healthcare fields become more adept at identifying nutritional deficiencies so that we can get patients presenting with one of these diseases the help that they need. Today, we're taking a look at riboflavin, or vitamin B2. So, firstly, we're going to go into the very basics behind deficiency of riboflavin. Then, we'll break down the science behind why patients are presenting the way that they do. Then, I'll give you some takeaways to help you identify this disease. When a patient has riboflavin deficiency, the first signs you are likely to find are lesions of lips and mouth, as well as a swollen tongue, which is glossitis. If riboflavin deficiency continues to develop, you will next see anemia, then finally neurological signs due to demyelinating peripheral neuropathy. That last bullet about the neuroscience is going to be very rare in people. It would definitely be much more likely that if a patient presents with all three of these presentations, that the neuroscience are likely coming from somewhere else, such as a different B vitamin. Because often, since they share very similar deficiency risk factors, we see that someone who's deficient in one B vitamin is very likely to be deficient in another. And other B vitamins also see neuroscience sooner than riboflavin. With that being said, I have a reason to believe I successfully diagnosed my friend's chicken with a B2 deficiency using neuroscience, as it turns out. It all started one day when I went to help my friend feed her chickens, and she's like, "Something's wrong with JLo. She's been acting real funny." No, this is important to the story because J Lo in this instance is actually a chicken, so not to be confused with that one actress from the 1997 film Anaconda. Now that we got that squared away, let's jump back into the chicken diagnosis. I see J Lo, and it's clear she's developed ataxia since the last time I've seen her. She looked like those wobbly cats on Instagram with the cerebellar issues, and they just wobble all over the place when they try to sit, walk, or run. And that's how JLo was looking. Nope, this is a full grown chicken that's been full grown for a while now. So I was thinking it must be a cerebellar issue that takes time to develop, like a tumor or a vitamin E deficiency. However, that's when I saw her run. And she ran in a perfectly coordinated straight line. It made me think back to those wobbly cats of Instagram with cerebellar disorders. Those things cannot run in a straight line to save their life. They're just as uncoordinated with that as they are with walking, if not worse. JLo, however, was coordinated with running, which made me switch my idea to sensory ataxia. And that made me think back to this textbook I've been using for these vitamin deficiency videos. That textbook often mentions the signs and symptoms of vitamin deficiencies in chickens. I did not have my textbook on me at the barn, so I whipped out my phone and started researching the different things I was seeing in JLo. And it was B2 deficiency that matched the best. She even had slightly curled toes, which is a neurosign in chickens often associated with B2 deficiency. So I told my friend my assessment. She gave JLo a B complex supplement, and let's just say your boy Matthew Webb's assessment was accurate. Now, since it was a B complex supplement, it truthfully could have been a different vitamin such as B12, but my ego was in the upper atmosphere. And JLo, she was one healthy clucking chicken. Now, after the fact, I did a little more research and came to realize that there were actually some differential diagnoses that I should have ruled out before settling on a B2 deficiency. And those were an injury that damaged the sciatic nerve, which was kind of unlikely in this case, as that would require a bilateral injury of the sciatic nerve, which occurred at the same time. So that's pretty unlikely in my opinion. However, Marek's disease, which is spelled Mareks disease, it presents very similarly to B2 deficiency, and I should have ruled it out. And bumblefoot was another disease I also should have ruled out. So I kind of jumped the gun on my diagnosis in this case, but I was right. So if you're not me and you're going to get it wrong, don't jump the gun. All right, that's all I got to say about that. Let's move on. So you can see here in the bottom left that the Krebs cycle utilizes riboflavin, but unlike thiamine, there are other processes that require more immediate riboflavin in high quantities. So unlike thiamine, neurological symptoms occur at a very late stage in this deficiency disease. One thing we know about riboflavin deficiency is that it impairs synthesis of mature insoluble collagen in the extracellular matrix. And that's the main reason we see tissue breakdown in tissues that remain consistently moist, like the tongue, lips, and mouth in general. There are two main mechanisms that have been proposed as reasons for impaired collagen synthesis. The first one can be seen at the top right of the slide, and it's that FAD, which is a riboflavin dependent essential cofactor, was actively required for lysyl oxidase or LOX activation. Now, lysyl oxidase is an enzyme required for collagen cross linking to make sure mature insoluble collagen forms. This theory, though, is based on some rat studies which occurred, I think, in the 80s. This mechanism is being phased out now, and we don't necessarily think FAD is required to activate LOX anymore. Instead, the secret to the conundrum appears to be held within the methionine and folate cycles. Let's go over this more in the next slide. So, riboflavin is required to recycle homocysteine in the methionine and folate cycles. The point in the cycles where deficiency of riboflavin could cause problems is either here or here. Interestingly, more sources seem to believe that it's here. If you can't see my mouse, I'm pointing to B2 plus MTHFR in the folate cycle on the bottom left. Note, riboflavin is in the form of FAD during the folate cycle. FAD is also required for MTHFR enzyme function. This deficiency causes homocysteine levels to rise. At the top right of the slide, we can see what can happen to collagen as a consequence of the rising homocysteine levels. A derivative of homocysteine called homocysteine thiolactone can physically prevent cross-linking in collagen by binding where the aldehyde group should be here. Here at the tip is the aldehyde functional group where my cursor is pointing. It's not there on the other side. On top of that, homocysteine can downregulate the gene that transcribes the mRNA necessary for LOX production. Both these things can lead to collagen being inhibited from becoming a stable, mature form. Instead, collagen fibrils become relatively structurally disorganized and fragile. Here's some risk factors you can look out for. Alcoholism impairs riboflavin absorption due to intestinal damage. Riboflavin is used up in alcohol metabolism. Alcohol acts as a diuretic, increasing urine production, thus increasing riboflavin excretion. Celiac disease damages the intestines and decreases absorption of riboflavin. This disease also requires a gluten free diet, but wheat products are fortified with riboflavin, meaning a major source is now unavailable to these individuals. Riboflavin transporter deficiency, or RTD, also known as Brown Violato von Leer syndrome, impairs mechanisms of transporting riboflavin throughout the body. This would be one of the few scenarios where people could experience neuropathy and neurodegeneration from purely riboflavin issues. Diuretics increase riboflavin excretion because riboflavin is a water soluble vitamin, so more is lost in urine. Antipsychotic medications, such as phenothiazines, impair the conversion of riboflavin to FMN and consequently FAD. Methotrexate is a chemotherapy medicine that is believed to compete with riboflavin for cellular transport. Some subjective questions asked would be about past medical history, and you should make note of celiac disease or RTD as well. Find out what medications they're taking. Make note of diuretics, phenothiazines, and chemotherapy drugs. Any alcohol consumption, and of course, find out what that looks like. Riboflavin deficiency is very common in people with severe alcohol use disorder. Some diseases that individuals can be at greater risk for with riboflavin deficiency are anemia, thyroid dysfunction, cataracts and glaucoma, and preeclampsia. For an observational clinical exam in the integumentary system, findings would be chelosis, which is swollen and inflamed lips, angular cheilitis, which is angular cracking at the corner of the lips. Oral findings would be observable swollen and red tongue or glossitis. Riboflavin deficiency is also likely to cause red eyes that the patient may describe as painful or itchy. The main takeaway as far as the what, why, and how behind the presentation is that the patient's lips are likely to be swollen or inflamed and have angular cracking at the corners. The tongue is also likely to be red and swollen. And this is characterized by an inhibition of collagen from becoming its mature, stable, insoluble form, leading to tissue breakdown in moist environments. This occurs because riboflavin, in the form of FAD, is required to utilize homocysteine in the methionine and folate cycles, which, without it, homocysteine levels rise. Homocysteine has a derivative called homocysteine thiolactone, which can bind to where the aldehyde functional groups are on collagen, which can physically prevent collagen cross-linking. High levels of homocysteine can also downregulate the gene that transcribes the mRNA necessary for LOX production. Both these things can lead to collagen being inhibited from becoming its stable, mature form. Instead, collagen fibrils become relatively structurally disorganized and fragile. And here are my resources. Thank you for watching. Note that I'm making these presentations during a pretty busy semester, so I'm liable to have made some mistakes. If so, let me know in the comments, and if your corrections check out, then I'll either add it to the video description or I'll pin your comment. If you learned something from this video and you want to learn more, continue on to my niacin or vitamin B3 video.